members and our board. And in that capacity, he attends our quarterly board meetings. He also very much contributes to helping us figure out our programming for our members, and he works very closely with Allison Gross and Chris Adamek, Director of Policy. He helps us with conference planning and really has his ear to the ground about what members are interested in. Early on, Marc supported the PCPCC in developing a number of our publications, and many of them are still on our website. So let me turn this over to Rob, and he will introduce the panelists and really manage the program going forward. Thanks so much.
Thanks, Anne. Appreciate the very kind words. And certainly my pleasure and privilege to be on the call today, and looking forward to a very interesting webinar and hearing from our speakers. We have a great lineup for all of you today. As Anne had mentioned, we're going to be having the speakers talk throughout the webinar. You can ask questions over the webinar using that function that you should see on your screens. And I'll just mention one more point before I share with you a bit about the speakers. Anne had mentioned about the executive members session that's after this call. We'll be on the phone for about 30 minutes. If you're an executive member, you can join us for that, and we would encourage you to do that, because it is a unique opportunity to be able to ask questions of the panelists who you'll hear from, and it's also, I think, a really good reason for those of you who may not currently be executive members to consider being an executive member of the PCPCC. It is a very unique and I would argue influential organization. I've seen it grow throughout the many years now, and if you're an organization that truly believes in primary care and the importance of it, and the important role that primary care plays in the delivery of healthcare throughout our country, if it's aligned to your mission and you're looking for an organization that can amplify your voice and advocate some of your key messages, and also an organization that is chock full of diversity. And Anne alluded to it before, but I'm hard pressed to think of another organization out there that has such diversity in its membership, touches virtually all parts of the healthcare system, and members, executive members, truly do gain key insights that they can bring back to their organizations as a result of being engaged at the executive member level with the PCPCC. So with that, welcome everybody today to the webinar that is focused on patient-centered care across the community. We have 3 speakers who will be sharing their experiences and expertise with all of us. I'm going to introduce all 3 speakers right now at once in terms of their bios, and then we're going to start off with our first panelist, and it's David Ehrenberger, who is currently the Chief Medical Officer at HealthTeamWorks. Dr. Ehrenberger shares responsibility for the continued expansion of the company's current core services, including practice network transformation solutions, training programs, and a membership solutions center. He's also on the front lines of providing consulting services to clients. Dr. Ehrenberger is a well-known figure in the field of practice transformation with 30 years of experience as a healthcare leader and as a practicing family physician. His leadership experience spans both community-based and hospital system healthcare, with roles over the past 13 years as Chief Medical Officer and CEO of an independent and high-performing clinically integrated network in Colorado, and as CMO of a community hospital in North Metro Denver. Our second speaker is Marc Rosen. He is a clinical integration technical advisor at YMCA of the of USA. It's let me say that again, YMCA of the USA. He provides technical assistance and training to local Ys as they explore and develop formal partnerships with healthcare systems, hospitals, and clinics in areas such as the YMCA's evidence-based health interventions, shared facility arrangements, or health navigation. Prior to his current role, Marc spent 3.5 years at YUSA, working on its chronic disease prevention programs team, helping local Ys prepare, implement, and sustain the YMCA's diabetes prevention program by sharing replicable and recommended practices. Marc has previous experience working on community-based chronic disease prevention or management programs with focuses on asthma and tobacco control. And last but certainly not least, we have Angie Wolff joining us today, who is a strategic consultant on Humana's bold goal, that's population health, team. Her work includes leading strategy, pilots, and initiatives related to making progress towards Humana's bold goal of improving community health 20% by 2020. Angie has been with Humana for 13 years. Prior to Bold Goal work, she was the clinical task force manager for the quality and STARS maximization team, where she led and managed strategy and human capital. She led the task force that developed and implemented programs to drive quality improvement in the clinical STARS metrics. Angie launched 20+ initiatives that support member health and well-being related to preventative screenings and education about the importance of screenings. She is a leader on the Humana Nursing Advisory Council as part of the Chief Nursing Office, as well as she participates in several Humana clinical and well-being committees. So with that, I am going to turn it over to Dr. David Ehrenberger to start us off. David?
Thank you very much, Rob. I appreciate your introduction. It looks like I have control. That's excellent. As this first slide indicates, I'm going to be introducing the concept of community integrated primary care. Don't bother looking it up. I think it's completely made up, but this is a discussion about the concept. It begins with the notion that we have been on a journey of defining the optimal scope of advanced primary care or primary care since the discipline of family medicine was established 50 years ago. It took a big jump now 10 years ago with when a bunch of renegades, including PCPCC and Paul Grundy and others, decided that the traditional model, the cottage model of primary care, wouldn't cut it. Introduced the notion of patient centering. And now I think that primary care, I think that advanced primary care, as is demonstrated by the patient-centered medical home, is once again being challenged. It's being challenged because I would say that it's one of its continued limitations is it's defined as a brick and mortar concept. And yet we know that patient centering may look like it begins and ends often within the medical model of PCMH and primary care. It might begin and end within the confines of an office, but in fact, perhaps the most powerful patient centering, particularly for at-risk patients, is outside of the office. This is becoming near and dear to leaders and innovators and thought leaders in primary care because of the logical plea and really demand that primary care begins to be hip with the social determinants of health in terms of assessment, intervention, coordination, because as we know, and as is very depressing for any primary care physician to learn, what we do within the medical model actually accounts for a minority of ultimate health outcomes. So this makes us think about public health and what is the role of public health within our new darling in primary care, which is population health management. There's a typo on this slide. It should say public health and population health management. So movers and shakers within, you know, as you say, thought leaders of primary care and expanding or defining the new scope of primary care are hard at work at figuring out how do we connect the social determinants of health, tools to understand and intervene. What does a team look like? Hard at work at trying to figure this out. There was really a great article now, I believe 2 years ago, in the Annals of Family Medicine, put out by Jennifer DeVoe, out of the Oregon Health and Science University, which correctly identified the importance of robust social determinants of health demographic assessment by the primary care team. Basically assessment and diagnosis, that the authors in this paper also implored folks to start thinking about, once we do master data, this new data field and collection of important data elements, what do we do with it? The implication was, in my mind, that this was yet another challenge for primary care to understand and to solve. The problem, of course, is that physicians, and particularly primary care physicians, are suffering currently from the so-called burnout epidemic. It's real, and anybody who's out there talking to primary care physicians in the trenches sees it. Also, we are currently undergoing a profound system and cultural change, i.e. the PCMH transition or transformation. So I would guess that we're only 50% or maybe even less of the way there of transforming primary care consistently across the United States in a walk the talk way. So we're hard pressed to add competencies around social determinants of health into the toolbox of primary care. Also, primary care remains firmly entrenched in the medical model and lacks the competencies of diagnosis and treatment of social determinants. The high resolution social determinants assessment and support actually occurs in the community, in the home and in relationships, and most often in other professional domains like public health and community-based services. And then finally, doing this expansion of primary care to accommodate effectively the assessment and, if you will, intervention or treatment or support of social determinant drivers of health really requires transformation and a new payment model to make it work. So what are we to do? Let me make sure I get this right. My slides. The first thing is, I think we need to consider that for primary care to be effective, it has to learn how to better integrate into the community, become a real community collaborator. And I know that others have talked about this. I will reinforce it, but beyond the three-part aim, of course, is the fourth part aim, which is the anti-burnout approach. I like to refer to it as provider and provider team vitality. And then there's the fifth aim, and that is you can be really good at part 1, 2, 3, and 4, and yet if the business model of primary care and perhaps it's a larger context, if that business model doesn't result in a going concern, then you still lose. So to get at social determinants of health, I'm making the case that primary care, as it's currently modeled in the beautiful model of PCMH, is overwhelmed and is hard pressed to change culturally and practically to be effective in the social determinants sphere. It really needs to learn how to be a better partner in the community. I'm referring to it as a health network here. And to engage in community clinical linkages. So the notion that there are explicit and professionally effective partnerships with non-medical purveyors of health services in the community, whether it's food banks or shelters or YMCA or what have you. And that this sort of collaboration also occurs across the medical networks themselves. So better coordination and collaboration across the medical specialties and primary care, where a lot of work is being done nationally. In addition, in order to have these kind of effective community clinical linkages that are focused on where people live, where they're at when it comes to health, we also need to understand what kind of new professional players have to be on the team, and then build accountable collaboration across that community. So it's not just about what the PCP practice is going to be paid as a PMPM, or perhaps what the Integrated Delivery Network or ACO will be paid in aggregate, or what kind of cost or savings, shared savings is going to occur. It's going to have to be, there are going to have to be payment models that look at how the community is compensated for the primary care that's delivered on behalf of medical and non-medical providers of health. So we've looked at how healthcare is delivered in terms of integrated delivery networks, which could be an ACO or a physician hospital organization or other accountable and collaborative organizations. And there are 11, as we count them, main driver pillars, key features and functions of networks that then result in 5-part AIM value. I've highlighted now 7 of them here that have solid line connections with impacting the social determinants of health. Hang on right here. 1 second here. This paper out of the Annals of Family Medicine talks about integrating community health workers into medical homes. So I had mentioned that an effective community clinical linkages really needs some workforce development that is not commonplace now. Of course, we've all heard of community health workers. Some of us are fortunate enough to have worked with them, but they are not standard. So Elizabeth Rogers and team at the University of Minnesota looked at what are the barriers barriers and other things that may actually be good for helping promote integration of community health workers into primary care and into a community. And they came up, or her team came up with 4 of them that were really important in terms of this integration with primary care. The first one was, of course, is leadership, as in informed advocates of community health workers. The second one is a clinical culture that's receptive to innovation, as in a learning organization. Third one was prioritization of patients' non-medical needs. For me, this is advanced patient centering. And finally, the organizations that were successful also considered how to make community health worker integration into the medical home or into primary care sustainable as a business. So beyond health, community health workers, other members of the expanded community integrated primary care team that I believe are essential in order to make patient centering happen across a community include health navigators. So people have different definitions for this concept, but the idea is to have one-on-one facilitation, particularly for high-risk patients as they navigate the community of medical and non-medical providers. Practice transformation coaching. This is near and dear to my heart from years of exposure to the heavy lifting that is required for practice transformation into PCMH. There is even more coaching necessary in order to address the cultural and operational changes that have to take place for there to be a firm handshake across the community between, say, a YMCA in primary care or a food bank and primary care. Executive physician leadership. By this I mean that there are physicians who speak business and have those disciplines and that work on behalf of, say, communities that wish to make this kind of advanced integration. The last piece is clinical analytics, and this could just be analytics period, but having primary care and primary care's partners in the medical community and in the non-medical community be adept at understanding data and using it on behalf of their patients to promote more prepared and patient-centered care is absolutely vital. So the second to last slide here, exploring attributes of high-value primary care. People are beginning to look intently on what constitutes the functional elements of primary care that then actually lead into outcomes that the business community and our patients and community members actually want. So definitely three-part aim is where it's at for these folks. And in this article, Melora Simon out of Stanford and team looked at just an enormous number of primary care practice sites and narrowed it down to the highest performing in terms of AAA performance, or at least quality and cost, and determined that there were 6 attributes of high-value primary care. There was decision support, careful selection, partnership with specialists across a network, advanced teamwork with standing orders and protocols, and payment models that made it worthwhile to grow and evolve your primary care practice. However, they also identified the importance of care coordination focused on high-risk patients, proactive outreach, and home visits, meaning that they reinforced that the social determinants competencies that were referenced earlier in my presentation are absolutely vital, and for primary care to be high value from the viewpoint of people who purchase primary care, we need to get jiggy with it. So practical takeaways for patient centering across the community. Think about the notion of community integrated primary care, namely that advanced primary care as a system property of a healthy community, not just of the brick and mortar concept. Consider what kind of workforce development needs to occur in order to bridge the current pervasive gaps between public health, community non-medical health providers, and the medical community itself. Think about measurement. Advocate for value-based payment models that extend beyond, again, the medical business constructs that we currently work in and extend out into the community to make it more likely that we have useful community-based resources for our patients that need non-medical services. Define the value proposition, embrace the employers and others that are more and more directly paying for healthcare in an intimate way with their local community, and then just make social determinants of health competencies and impact happen. Get started, start small. I think we're going to hear some of that from the other speakers. And from my viewpoint as a lifelong family physician and one that is witnessing what I consider the primary care pile-on phenomenon, just say no to making social determinants of health just an issue of primary care in the modeling and design of the next phase of primary care. Thank you very much.
Great. Thank you, David. Appreciate that. We're going to transition over to Marc now, who will be speaking from the vantage point of the YMCA. So Marc Rosen, over to you.
All right. Thank you very much. And David, I feel like a lot of what you shared really integrates and sets up nicely for what I'm going to be talking about from a community-based organization perspective. So really, I think what I hope to discuss are trends in population health and the role of the Y in that healthcare transformation, the Y's infrastructure for delivery of chronic disease prevention programs, and then sharing some leading practices for clinical integration between healthcare organizations and community-based organizations. And so I think to start with, talk about trends in population health that are, of course, familiar to everyone on the line. And we know that health reform efforts are shifting the financial incentives in the healthcare system to from a fee-for-service to a value-based payment model that involves alternative payment models. And we really feel that in order to be successful in a value-based payment contract, it does require a progressive population health strategy that provides the right intervention to the right patient at the right time. And this really aligns with the goals of the various healthcare delivery and payment reform efforts, whether it's alternative payment models like accountable care organizations, bundled payments, comprehensive primary care plus, or Medicaid managed care. Ultimately, the approach can really enhance the ability of providers to understand what happens to their patients once they leave their clinical walls, and which is really critical to succeeding in that value-based care environment. And David mentioned it, and I'm just going to sort of re-emphasize it, that the Robert Wood Johnson Foundation study estimates that only about 20% of the factors that influence a person's health are related to access and quality of care, whereas the other 80% are due to socioeconomic, environmental, and behavioral factors. But we know how critical the word of primary care and healthcare providers is to the patient. And so the more that we can be bridging that gap between clinic and to community, the more opportunity there is to be successful in a value-based reimbursement environment. And so we often talk about it, the Y, community integrated health model. And I know that this is a term that isn't necessarily new, but when we use it at the Y, we're using it very intentionally to convey a model that fully integrates community-based organizations into a population health strategy, rather than including them in a tangential role, because we know from studies that community-based prevention efforts demonstrate patients' improved ability to self-manage their diseases. And really, a community-integrated health model is one that integrates health systems, providers, and community-based health promotion programs to address the breadth of health issues facing a population. And key elements of success in a community-integrated health model from our perspective are going to include treatment strategies that fully implement primary, secondary, and tertiary prevention, clinical pathways that are supporting patients getting into the right intervention based on their risk and identifying who those high-risk patients are to begin with, and then making sure that those interventions can be provided to those patients in community settings and that they are evidence-based. And so this really leads to my next slide, which talks about the portfolio of evidence-based health programs that YMCA of the USA discovers, develops, and disseminates on behalf of the YMCA movement, which is comprised of a federated network of YMCAs. So all of these interventions that have gone through randomized controlled trials, and Ys around the country have the choice to adopt and implement these programs in their communities and really receive support around best practices from the National Resource Office at YMCA of the USA, which is based in Chicago and where I work. And so the YMCA's Diabetes Prevention Program is the program that has gained the most notoriety due to the Y's leading role in demonstrating cost savings that led Medicare to establishing the Diabetes Prevention Program as a Part B benefit. But all of these programs together really represent what we consider to be the quote unquote pool of the 21st century, and the infrastructure and investment in this infrastructure that we've made as a movement of YMCAs over the past several years. And when we combine the portfolio of evidence-based health programs with the Y's footprint around the country, being in 10,000 communities approximately, through our 2,700 branches, we really believe that the Y is positioned to play a meaningful role in population health in partnership with healthcare and ultimately improve the health of the communities we serve. But I would add that it's not just the Y. We believe that community-based organizations in general are situated to play a role that is meaningful because in many ways they're already providing interventions that can impact, as David was saying, the social determinants of health that do have impacts on clinical and quality cost measures. And so I'm just going to briefly talk about some clinic to community partnerships that are budding and taking place today. What I would say to start it off, though, is that, of course, obesity, as you can see here, is something that continues to grow in our country. And it's an issue that Ys have long been a part of in order to be a part of the solution in their local communities. And I mention obesity specifically because this is something that we are seeing coming up in a lot of clinical integration partnerships around the country. And the Y's role, at least over the past 20 years or so, has been engaged in coalition work that's really intended to help implement policy systems, environmental changes that address the prevalence of obesity and ultimately making the healthy choice the easy choice. But I add this because being viewed as a key stakeholder in addressing this public health issue has really laid the foundation for Ys to explore formal clinical integration partnerships with healthcare organizations and payers. And we continue to see, as I mentioned, obesity be an area of key interest for those stakeholders, since it does have significant implications in performance for value-based contracts, for MIPS, and alternative payment models. And so more specifically, I would say there are a variety of budding partnerships, clinical integration partnerships taking place around addressing the obesity and the cardiometabolic syndrome. And we're seeing Ys and their healthcare organizations, whether it's diabetes centers, primary care practices, ACOs, orthopedic practices, really have an intense interest in this area. And many of the opportunities for healthcare organizations and Ys really revolves around developing shared population health strategies that, as I mentioned before, integrate primary, secondary, tertiary prevention approaches to addressing cardiometabolic syndrome and ensuring that access to interventions in community settings where patients work, live, play, and pray is provided. And so, for example, in terms of obesity, there are many Ys providing evidence-informed weight loss interventions that really can provide the support necessary for sustained behavior change around nutrition and physical activity choices. I think in this area, we're seeing Ys have forming partnerships to play a role as a third-party organization providing prehab and/or post-hab interventions for weight loss surgery candidates in order to really optimize their eligibility for surgery and the outcomes that those patients achieve, of course. And this nicely aligns with existing benefits like intensive behavioral therapy for obesity to really ensure, like David was mentioning, that the sustainability model is extended to community-based organizations because it's a win for everybody then. Of course, pre-diabetes, I mentioned previously about the YMCA's diabetes prevention program, as the Y is the largest in-person provider of this program, and there are unique billing codes for this intervention as well, which allows nicely, that it sets it up nicely for sustainability from a partnership perspective as well. Diabetes management is something that we're seeing and come up in many conversations. There are many Ys that have registered dietitians on staff who provide nutritional services. And with this staffing in place and the shared goal to address diabetes management across performance areas like ACOs and HEDIS and MIPS, this is a conversation that is of high interest in clinical integration partnership conversations. And whether I would say that, Ys are positioned in many ways to provide diabetes self-management training, medical nutrition therapy. And in the case of Western North Carolina, we've seen a YMCA and a large health system collaborate to develop and evaluate a taking control type 2 diabetes program that really provides wraparound support services to patients in diabetes self-management training, but all with an eye towards sustainability upfront and shared metrics in place. I'll share briefly hypertension, the YMCA's blood pressure self-management, self-monitoring program really, I think we're seeing that come up as an opportunity to help patients improve their blood pressure control, encourage patients to record their readings at home and get those readings back to providers for the purposes of regular adherence to appointments and also adjusting medications. And of course, this does align with newly announced benefits around remote patient monitoring. And then lastly, arthritis and joint disease is another area that we're seeing come up a lot in conversations locally. And I think, there are Ys engaged in clinical integration partnership conversations, again, around pre and or post-HAB interventions for arthritis management, falls prevention, as that is a metric that's, is important across modalities. And in a lot of ways, this is coming up more and more as health systems are engaged in bundled payments around lower extremity joint replacement, and seeing that obesity and arthritis are comorbidities that, are key to address in that population. So I'm just going to share 2 more slides briefly, and this is sort of a takeaway, if you will, on what we're seeing as characteristics of successful clinical integration partnerships. I think that, we believe that clinical integration between a CBO, a community-based organization like the Y, and the healthcare partner should have a clearly defined pathway that creates shared accountability and sets the partnership up for long-term success and sustainability. And so some key characteristics of that are there needs to be a partnership goal and corresponding measures, whether they're both process and outcome measures, that address population health. So there is a shared clinical integration strategy up front. And that shared strategy should really involve and lead to referrals to evidence-based preventive health strategies and programs. But there has to be shared accountability and outcomes there. And a process to target the population at risk, develop a referral pattern with bidirectional data sharing, and this will ultimately lead to the delivery of a defined set of interventions that can be measured because data sharing needs and practices have been outlined by both partners up front. And that there is really referrals that are being sent as part of that partnership. And of course, that will allow the community-based organization to deliver their intervention and then demonstrate outcomes relevant to providers and share those back. And even though a shared plan for sustaining the model is listed third here, I would say that that conversation needs to be developed early on in the partnership. And each organization really receives value from the partnership, and therefore both should be involved in devising and advancing a plan to sustain the partnership that really aligns interventions with payment systems so that the model can be sustained and grown. Really, like David mentioned, how the contract needs to be extended beyond the health system. And then lastly, ongoing partnership evaluation is critical to sustaining a partnership. And there needs to be that feedback loop in place to make sure that it's successful. So I'm just going to finish off here and pass off to Angie. What I would say is that we are actively involved in documenting best practice models of community integrated health. Originally in partnership with and support from the Robert Wood Johnson Foundation, but more recently in partnership with PCPCC as well, we began implementing a broad national initiative to support the expansion of community integrated health, to provide technical assistance to support clinical integration between local Ys and their healthcare partners, identify best practice models, document them, and really disseminate and replicate them throughout the country. So the dots on the screen that you can see are the 15 local YMCAs where we're providing intensive technical support for clinical integration, but it really is extending beyond just these 15 Ys. And to that, I will pass it off to Angie.
Thanks, Marc, and appreciate the overview and also the linkage back to David's presentation on HealthTeamWorks. So thanks for that, and I'm going to turn it over to Angie right now. Angie?
Thanks, Rob. Can you hear me okay?
Yeah, just fine. Yep.
All right. Well, good afternoon, everyone. My name is Angie Wolff. I am from Humana, and I am part of our Bold Goal team in the Office of the Chief Medical Officer. I'm actually sitting in Louisville, Kentucky at our corporate office, but I'll talk to you today about the communities where we have our bold goals and where we're doing our work. And I just thank you, David and Marc, for setting me up for such an easy talk, because I totally agree with what you're saying in terms of health happens, good healthcare happens not only in the office, but outside of the office and in those community areas. And so hopefully I can wrap it up and kind of bring it all together. And make sure my slides are going to work here. So if you've ever tried to get healthy or stay healthy, you know that good health is really hard. Making those decisions to eat the right things and drink the right things and walk the number of steps that you need to walk, and just making those healthy choices. You know, making choices of cooking in a lower fat oil, or maybe not eating something that's fried. You know that it's really hard. Good health is hard. And that's really why we established our goal, because it's hard. And what makes it hard? It makes it hard because of the complexity of our healthcare system. And so if you look at this slide, it makes me dizzy every time I look at it. It's, our poor patient is right there in the middle. Their caregivers are there. Their PCP is there. All those things that are so critically important to our patients and the healthcare that they deserve. But there's so many things to take care of and so many complexities. And it's just this huge web of tangled mess. And so really that's another driving force behind why we set our bold goal. Our bold goal of helping the communities that we serve become 20% healthier by 2020. Let me say it again, 20% healthier by 2020. We're really, really close to that. So we're coming upon our deadline, and we're really just running to meet that goal. This is more about our bold goal. The communities that we serve will be 20% healthier by 2020 because we help make it easier for people to achieve their best health. And again, it's not just inside the physician office. It's outside of that clinical setting. It's in the community, and it's by focusing on those social determinants of health. So you'll see that this is really where we believe we're going to make a difference, by focusing on the social determinants of health, the partnerships, and Marc, I really love that so many of your slides said partnerships, because that is indeed what this is really built on, is the partnerships between our clinical partners, our community partners, and others, and those members of the community health workers that you spoke about, David. So those are so important to really being able to meet this goal and to helping the communities that we serve become healthier. We're also going to talk about healthy days and some of the research that we do around this healthy days and how we measure our bold goal. And I'll get to that in just a few minutes. So this is really where we're striving to go, into that integrated healthcare system, because again, we know it's not just what happens inside the office. It's all of these factors that are impacting our patients from the community. It's the access to healthy food, making sure, it's not only making sure that you're making the correct choices, but when you only have poor choices that are around you, it's hard to make that choice. So if you live in a food desert, or if you maybe don't have time or transportation to get to that grocery where it has the fresh local produce, that can make it challenging. If you aren't sure how to eat and you have diabetes, like Marc was speaking of, it's, those diabetes programs are going to help support that. So it's really integrating all of these pieces together and really developing those partnerships so that our patients and can work along with that trusted partner, which we have learned and really firmly believe that physician is the trusted partner. That's that person that is really that key link, and that is a valuable piece. So another reason why we're doing this, it's a great opportunity. We really want to build these relationships with people like David, like Marc, like the YMCA, like our local government officials. We do that here in Louisville. We have health advisory boards that our health departments are sitting on, and that they're coming to and saying, here's what's really going on in the community. And we're listening so that we know how can we help our communities become 20% healthier, so that we really know the problems that are impacting our communities and the barriers, such as in Louisville, the poor air quality, or such as in, in San Antonio with diabetes, and in so many of our communities with diabetes. And so really working locally in the communities that we're in is going to help us make the health of the community better. These are the communities that we're in. All of the green dots are the phase 1 communities where we've listened and we've learned. These are really where we started out. These were our foundational bold goal communities where we really just started our work. San Antonio was the very first one. And I'll tell you a quick story that involved the YMCA and a physician practice in San Antonio. We teamed up with the physician practice, and the physician practice identified those members that had pre-diabetes. And then a local grocer in San Antonio had registered dietitians on staff, and they helped those members that were identified really visit the grocery and learn what were those key items that were really going to help that member avoid, stay as a pre-diabetic and not turn into a diabetic. And so they gave them store tours, they gave them cooking demonstrations. And then just that added addition, which we know is so important, is that the YMCA was also a partner in that learning opportunity. And the members were able to go there and learn about physical activity and exercise that would help prevent diabetes. And so that's just one example of some of the work that we're doing in these communities. Our phase 2 communities are where we've expanded and where we're doing further learnings. And so we continue to look at where we have opportunities. Food insecurity is one of our biggest focuses because we know that 1 in 8 Americans is food insecure, and it impacts you across the whole family, across from everything from a child to a senior. Of course, we have a huge senior population, and so that's something that we are very focused on. It also is one of our biggest drivers of unhealthy days. And that is how we're measuring our bold goal, is through unhealthy days. And I'll describe that in just another slide. But this is something that the lack of access to enough food for a healthy, active life is the definition of food insecurity. And so it's not just about making sure that you have those 2 packets of ramen in the cabinet to get by. It's making sure that you have access to food to be able to stay nutritionally well, and to make sure that you have enough food that's going to feed you and your family. It's not just those people, it's their entire family. So let's talk a little bit about how we're measuring what we're doing. This is really our barometer of success. We look at healthy days in not only leading indicators through our pilots and programs like what I described with the YMCA and the physician practice and the local grocer. So that was an example of where we use the healthy days as a leading indicator. We also use it as a lagging indicator. So we look at each of our bold goal communities and we ask these 2 questions, the physically unhealthy days question and the mentally unhealthy days question. And we look at those. Those are a measure that the CDC developed around 30-something years ago. It's been around for a long time. We like it because it looks at the whole person. We know it's not just your physical health. We know it's not just your mental health. It's your total number of unhealthy days. And we use this to understand if we're making a difference. And I'll show you at the very end of the presentation where you can go and look at our communities and look to see the progress that we've made in reducing the number of unhealthy days that our members are reporting. Our goal is to give back more healthy days. We want our communities, not only our members, our communities, to have more healthy days. So this is why we're doing what we're doing. We think it's bold. We want to help make health easier. We want to reduce costs, and we want to improve clinical outcomes. And we're doing all this through our work with our partners, our physician partners, our YMCA partners, all of our community partners that we're teaming up with. And these are the things that I referenced that I was talking about. If you go to humana.com/boldgoal, you can find our toolkits for food insecurity, as well as our Bold Goal Progress Report that will show you each of our communities and what the healthy days are for those communities. And so I just really, between the 2 other speakers that were here today, I think it in summary, it's really about that partnership. It's not about, David said something, it's not just that primary care pylon. It shouldn't be about just the primary care physician taking care of all of these issues. This is a joint partnership effort. And so that's really what we're dedicated to here at Humana, and we're really excited about this, and we love partnering with our community partners and our physicians because it really gives us a chance to make a big impact. So Rob, I'll turn it over back to you.
Great, thanks, Angie. Well done to all the speakers. I love the flow and the relationships between all of the speakers' points of view around this important topic. Angie, since you were the last speaker, and you're still probably right there at your phone, I have a question for you that came in about your presentation. The question is, does Humana have any Medicare Advantage plans in an American Indian, Alaskan Native community or reservation?
Yeah, that's a great question, Rob. And I'm sure that we probably have some sort of, I don't know that we have it specifically in a community, but I would venture that we have some membership that covers that demographic. But I'd be happy to, if there's a specific community that someone is thinking of, I'd be happy to answer any questions or provide some more information about our Bold Goal work and see if that's in that specific community. Okay,
great. Thanks. And we can also, the person who asked the question can also direct the question back to PCPCC, and they can also facilitate that. So thanks for the question. Another question related to your presentation. When is the payment model going to catch up?
Great question. I will say I'm not sure if I'm the right person to answer the question about the payment model, but I will tell you that some really exciting news that most of you probably have recently seen is the CMS memo that shared about allowing for payment for things like groceries and air conditioning and some of the different things that are really challenges. And so that's something that we're really excited about, and we're looking at to see how this will impact and how it can make a difference.
Great. And are the Humana programs specific and only for Humana members? And if yes, how did let's ask that question. Are the Humana programs specific and only for Humana members, is what she asked.
No, they are. Many of the test and learn pilots that we do, many of our testing and learning, Rob, are done with our Humana membership, because that's where we have the ability to understand unhealthy days information. But no, all of the programs that we have, such as a randomized control trial that we're doing in Florida, we are testing and learning. It is a trial, but it's open to every member of the community that is a member of that physician practice. And that's true across the board for many of our pilots and programs.
Great. Thanks, Angie. Hang on the line. I might have another one or two for you. Let me turn over to Marc and the YMCA. Question came in about, do all the YMCAs have what you had shared available? The individual had never heard of the program, and she was interested in knowing if all the Ys had that available.
Yeah, that's a really good question. We are a federated nonprofit system, which essentially means that each YMCA is governed by their own independent, board of directors as a 501c3, but they do have the opportunity to sort of take on these nationally supported programs and initiatives. So it is going to be a local decision whether a YMCA is offering the full suite of evidence-based health programs. And I'd be happy to help somebody find out if their local YMCA is where they're at in that process, and if there's interest in facilitating a connection to help that conversation take place.
Great. And here was another question related to the Y. What options do we have when the local YMCA does not appear to have staff who are interested or skilled in engaging with the health system on an integrated approach to population health. Are there coaching or incentives or other ways that someone can be brought into this initiative and support an initiative like this at the federation or at the broader Y level?
Yeah, so definitely at YUSA, where I'm at, we're always happy to support those conversations and help them get set up successfully from the start. Just like healthcare is undergoing massive transformation, as a YMCA movement, we're undergoing a lot of transformation as well, because we're, the Y being known as a gym and swim, which we still do really well. We're also shifting more, as I mentioned, towards addressing chronic disease and have been. So that means that we're trying to coach and train staff and provide resources internally as well. And we're happy to support those conversations and make sure that our staff and partners get what they need to make sure they're successful.
Great. Well, thank you, Marc, for that response, as well as your presentation. And I'd like to also thank David and Angie. I think as I mentioned before, the flow across your presentations really shows how important the collaborative approach here is when it comes to the community engagement. And we appreciate all of the thoughts and ideas that you shared today. And if anybody has any follow-up questions, and if you're an executive member, you could stay on to the next. There's a separate call-in number you can use and continue the discussion for the next 30 minutes. And if not, if you have follow-up questions, you could always check in directly with the PCPCC, and they'll do their best to field the questions and direct them appropriately. So with that, thanks to all of the speakers, and also to the PCPCC staff and leadership for coordinating this webinar today. Great job, guys, and looking forward to the next webinar, which I think Anne had teed up early in her presentation during the course of this discussion. So look forward to the next one, and everybody have a great day.
Thanks.